Hi, I'm Jeff Forster, and I'm the host of A Doctor's in the House, and it is our privilege to be joined today with Dr. Singh and Dr. Baciewicz. And the purpose of our show is to get a local perspective on the COVID-19 response and the virus itself. And we're very excited about today's episode as we begin to dig into some of the experiences that Dr. Baciewicz is experiencing at the hospital he's serving at. Dr. Singh, as you know, has been on the show every episode, and so it's always good to have you here, Dr. Singh.
Thank you.
Good. And then Dr. Baciewicz is a cardiothoracic surgeon at the Detroit Medical Center and has been working specifically with COVID-19 patients. Dr. Baciewicz, thank you for joining us today.
My pleasure to be here.
Good. So, Dr. Singh, give us just kind of an overview of where you feel like we're at right now with the COVID-19 virus here in the U.S.
Well, like I said before, good morning, and we're at that stage in which we're seeing we're hoping to get that plateau phase of these patients, and it depends on which hospitals you're at. So obviously, a couple of weeks ago, we had Michelle from the ER in Riverview District and talking about what's going on there on the ER. It's a different scene in Detroit with Dr. Baciewicz. Will tell you, Dr. Baciewicz is a good friend of mine. We used to be in the OR together a while back, and he's a great surgeon, great thoracic guy. And he was quarantined, by the way, for 14 days waiting for his testing results. He was just telling me he was dealing with COVID patients and how he was doing. So I asked him to come in and give us an insight, and he will give you the layers of how the operations are going on at the DMC.
So, Dr. Baciewicz, tell us about that. So you've been working directly with COVID patients there at the DMC?
Well, most of the patients, you have to consider that they're all been exposed to COVID, any patients that's in the hospital, but some specifically are COVID positive, and some of them are untested, and then other ones are COVID negative. So yeah, I've been dealing with all categories of patients.
Wow. So then the pressure that you're experiencing there at the Detroit Medical Center is pretty significant. I know, like you mentioned, talking to the previous doctor there in Riverview, she had mentioned that it wasn't so heavy, not such a heavy response there, but there at the DMC you're seeing a very high number of COVID or potentially COVID-19 patients?
Yes, being in the heart of downtown Detroit and the hospital, with the hospital's locale, we serve a high number of patients who typically don't have regular doctors, who come in only when they have medical problems. And we serve a large number of African-American patients also. And as you know, these patients have been specifically, or more significantly, been hit with the virus. So the situation is such that we're not doing elective operations because we're saving the resources, that being the ventilators, and the operating room ventilators have been used for patients who need ventilators. So we're only really using some of the operating rooms, not all of them, because some of those ventilators have been in the recovery room which has been turned into another COVID ventilator unit. So the number of operating rooms isn't the same as usual. So all elective operations are not being done, only emergency operations. And like I said, one reason for that is because the ventilator to use. The other reason is to save some of these supplies. We're not able to get, just to give you an example, N95 masks, unless we specifically request them. They aren't just sitting on floors. Same things with protective gowns. If you want one, you have to go request one. They're not just sitting outside the room. So things have changed. We're not doing elective operations. I do heart and lung surgery specifically. And for example, in the last month, as Dr. Singh mentioned, I had a sore throat and some clogged up ears. So several of the infectious disease doctors at the hospital thought I should get a COVID test. And they told me the turnaround time would be 48 hours. So, being a doctor, I believed my doctors, and I went and got the test. And, unfortunately, the test, the results were not available within 48 hours. In fact, I waited 12 days to get the test back. So that meant that I did not go to the hospital because of the possibility that I was shedding virus or could, even though I was, if you might say, slightly symptomatic,
right.
some sore throat, I didn't want to potentially infect other people.
Well, Frank, we're glad you're okay, and I think the new test that's coming is a little bit more rapid. What I was hoping you would tell us also when we were discussing, the levels of COVID. So the different floors, different wards having different levels of the COVID. If you could explain that, starting from the primary when they're coming in from the ER, and what are the levels that you see of escalation with the COVID patients?
Well, obviously, there's several categories. There's patients that come in to the emergency room with symptoms who may have it, may not have it, but are clinically stable. They get sent home. Then there's patients who are brought into the hospital and are tested, and we have to wait for the test to come back. Those patients are typically on the floors. And then there's the patients that are symptomatic. These patients are put into isolation rooms, and you need gowns, masks to get into those particular rooms. When their tests turn positive, that obviously puts them in strict isolation. And if they become symptomatic, particularly short of breath, they get transferred to an intensive care unit where they can, receive either minimally invasive or additional oxygen. That's high flow liters per minute of oxygen, or if it's necessary, to get intubated. So there's several, as I mentioned, several levels. Now, the hospital has also tried to keep units, COVID positive units and COVID negative units. In other words, units that might be just taking care of regular patients, for example, or patients that have tested negative for COVID, say have abdominal pain or some other issue like that. But unfortunately, what's happened with the deluge of COVID patients, there's basically no units in the hospital now that don't have COVID positive patients on them.
So are you feeling like we're getting to the limit of our capacity there in the city of Detroit, our hospital room capacity? Or because I know, the TCF facility there, the field hospital, they had limited number of patients. Are we starting to stretch that, or do you think we're coming to the end of the pressure on your specific capacity in the hospitals?
Well, like I said, every ICU now is filled with COVID positive patients, and the last intensive care unit that had no COVID positive patients in it now has 2 COVID positive patients in it. So there's no units that don't have COVID positive patients now. I don't have hospital numbers to tell you because I'm not with the infectious disease teams, but if you look at the statewide numbers, it seems to have leveled off in terms of numbers. But from the hospital standpoint, we're still pretty full with COVID patients. So I would think that any additional overflow would go to the former Cobo Center downtown. Yeah. But the hospital is full now, and there are COVID patients on all units.
So I guess, Dr. Singh, you probably have some thoughts on this, but I know that Detroit is in the top 3 or 4 hot spots in the country. And so as the president and the task force recently yesterday began to lay out the process for reopening the country, they did highlight the fact that they understand that some of the hot spots are going to linger for a while. And are you seeing that? Do you anticipate that here in Detroit, that it'll linger longer than a lot of the other areas in the country?
Yes, I mean, just the sheer fact of the density and the size of the population as well. So we don't have, we're not in the country, obviously accessing groceries and transportation. It's a little bit more difficult than major cities. And you're finding that globally as well. Cities like Toronto, New York, obviously, Dubai, sorry, not Dubai, Bombay, and places like that, you're seeing major differences in the way large cities are operating versus the rural areas. And again, it's a population density. So Frank and I were discussing of the progression of this disease. And so we were talking, he says he believes that most of these people, most of us will end up getting or exposed to this virus at an ultimate point. Frank, what's your thoughts on that? And I'd like you to discuss that a little bit further and our thoughts that we were discussing the other day.
That's a good question.
In terms of, do we think we're all going to get exposed to the virus?
Yeah.
Well, I think that, probably at least a third to half the country will get exposed to the virus. And how many are going to, supposedly 80% are asymptomatic or not symptomatic. So I don't know. I think, as the national experts or Dr. Fauci and all the other people that mentioned that we need a good testing system here to figure out what to do, how to reopen the country. But I think, as Dr. Singh just mentioned, it's going to linger in Detroit for some time yet. I don't think it's unrealistic to think that we're going to be back to normal in 2 weeks, because patients are still going to be coming into the hospital, I think, for a couple of weeks at least. So I don't see any return to normal for, at least 3 or 4 weeks. When I say normal, I'm talking about, these phase 1 and phase 2 things that President Trump had outlined last evening, at least in the Detroit area.
Right. Well, I'm certainly not a medical.
And then just one other issue. I mean, we thought that patients needed to be only quarantined for 14 days, or patients that had been exposed to the virus. But it looks like from some data that their patients, may still be shedding the virus at 28 and 30 days afterwards. So, it's a lot of these things are really unknown about what's going to happen down the road. And as one commentator said, you only get one chance at this. It's like surgery. You don't get a lot of chances. You don't get to do do-overs in this.
Right.
So I think we should be, myself, I favor a more conservative approach to this because of that.
So, I'm just a layman. I'm not a medical doctor, but it makes sense to me that if this virus is novel, which means we've never, as humans, ever encountered it before, that would mean none of us have an immunity to it. So the only way to stop this would be like with SARS, where it seemed to have died out on its own, or we have to all have an immunity of some form. And the option for immunity would either be immunizations, vaccines, or enough people have gotten it that the herd has slowed down the spread. Are those the only two options, or is there a third or fourth option out there?
Well, I think you're right on. There's a lot of unknowns on this, so I think but as scientists, we're getting more metrics in. For example, weather may change, or like you said, SARS died out. The virus is mutating. But the other frontline assault on this thing is that we're actually finding medications that work, so we can have sectors of where we know the transmission, the vectors, so we can minimize the damage by doing that and containing it.
Right.
But this will be resolved when immunization or medications that we can take that we know that can attack it, bring it down, until permanent solutions like I said, the immunizations work on this.
Right. So then now, as we're looking at trying to reopen the country at some point, and like Dr. Fauci said, there's not going to be a light switch where suddenly everything's back to normal, but we can't just stay shut down forever either. So as we begin to start to work that out, paying attention to the hot spots is going to be a big part of that process. And what about that testing then? I think that Dr. Baciewicz, you mentioned, the need for testing. Are you talking about like antibody type testing to where we can have a general understanding of what the population exposure is? Because if 80% of the people are asymptomatic, how would we know when we've reached a threshold where it's fairly safe for most people?
Well, first of all, you're talking to a cardiothoracic surgeon.
Yeah.
So my expertise on infectious diseases and antibody levels and things like that is probably not best in the world. But all these tests that have been used so far, the nasopharyngeal swabs, and those only have a 70% sensitivity. We don't know what the antibody tests are. We're assuming that everybody that's been exposed is going to have a reasonable antibody level. I can't answer that for you. I don't even know if the people that are getting the results can give you an answer to that. But my understanding is that even an antibody test is not 100%. Everybody develops different immunity to the disease, So it may be that not everybody's going to react the same. And even if you've been exposed to the virus one time, if you're exposed to it again, you may contract the disease again. These are all things we don't know about here, which is why I'm concerned that rushing to open the country, even though I'm not an infectious disease expert, worries me. Because, like I said, I think you only get one shot at this, and a second big spike, if we have another big spike like this, is going to be disastrous for the economy. It is already disastrous enough as it is now with, the economy was down 8%, like even worse than the recent recession. And I don't know how it compares to the Great Recession back in the 20s, but it's be a very worrisome thing. So I think, doing it in gradual stages and rolling this out very slowly and conservatively when we have a little bit, more information would be better. And one of the problems with information is that we need a good concerted national effort to look at all the data. Different hospitals are doing various testings and they have small numbers of patients, but we really need a national effort, I think, to look at the data and figure out what we're going to do. And this is an opportunity to do it. Maybe even international, pull the data internationally, because just having one hospital do it is not going to work.
So
Absolutely.
I had a question about, talking about the information, and there's a lot of information about what this seems to be doing, like on almost a pneumonia kind of a level, the lungs, the damage to the lungs. But I've also seen a lot of reports that it's also doing some significant damage to the heart and to kidneys, seem to also be pretty significant. So you being a thoracic surgeon focusing on hearts and lungs, are you seeing some unique attacks on the heart that is different from other corona type viruses or other flu type viruses?
Yeah, again, there's troponins are a blood test which are obtained for patients that have heart attacks. Okay, these troponins are elevated in the blood typically. So it appears that all the patients that are exposed to the coronavirus do have cardiac damage. Okay, and to the point that they're not really doing echoes on all these patients to look at heart function, but almost all the patients that come in who are COVID positive do have elevated troponins in the blood, which means that you do have some heart damage from this. Now, I will tell you, the cardiothoracic team at our hospital, when patients' lungs are failing, because that's the main reason that people are expiring from this, as with the flu, people get respiratory difficulties. So we have a couple of patients in the hospital on ECMO, or extracorporeal membrane oxygenators, which are take their blood, put oxygen in, and put it back. We have 2 patients in the hospital currently with COVID infections on these machines, trying to give their lungs time to get better. Now, interestingly, some institutions, some of the patients get cardiac damage, and some institutions have placed patients on not only devices which increase the oxygen in the blood, but take over the work of a heart also. Unfortunately, none of those patients, to my knowledge, who have been put on arterial venous ECMO, as compared to just venous, where you're just putting oxygen in the blood, none of those patients have survived. So the current thinking is that if patients are developing severe heart problems from the virus, that putting the patients on arterial and venous ECMO, in other words, to support both the lung and the heart, has not been successful. So that's not being done. for only the places that, do ECMO, and there are just a few places in the state, been confined to just using venous ECMO to support the lungs. And in terms of kidney damage, I really can't speak to that, but usually when patients are getting intensive care units and they have systemic disease, the kidney is a very sensitive organ, and so it typically does develop damage. I don't know if that's primarily because of the decrease in oxygen levels that these patients see, or it's because of the inflammatory response. The kidneys are typically a very sensitive organ also. So I don't know if it's primary or secondary on the kidneys, but clearly the heart does get affected with the COVID virus.
Yeah, Dr. Frank, where do you think this is going? We were talking about ending this, at least seeing a plateau. Do you think we're in the plateau where we were discussing?
Well, based on the information that New York State puts out every day, it looks like the numbers are staying the same in New York, and it looks like the same thing in Michigan. We seem to have less deaths, we have less deaths, I think, yesterday, and they seem to be declining, and the number of patients that are new, diagnoses every day seem to be about the same. And we're clearly running more tests in Michigan now than we were before. So to me, that seems like a positive thing. That the tests, we're doing more tests, but the number of additional patients with the diagnosis per day and the number of deaths per day seem to be staying the same or declining. And I think the death rate's going to persist for a while, because people who contract the disease, they don't necessarily get sick just on day one. Some patients who are, have had symptoms for 10 or 14 days before they come in the hospital, or even patients are in the hospital for a number of days before they require a ventilator. So I think the death figures will lag a little bit, but I think the numbers to look at is how many more patients are being diagnosed every day, because we're now clearly doing more testing, at least in Detroit and other places. So I think, like they say, the death rate staying the same should hopefully decrease. And I'm encouraged by the fact that there's more people aren't being diagnosed every day.
Yeah, it seems like the testing rate is going up and the death rate is starting to level off, right? So that winds up being good news as we get more testing and the death rate stays, then the percentage of people dying from it will continue to go down. Not to minimize the people who are dying. I mean, every life is important, but what that tends to mean is for the general population, perhaps, there's a little bit more breathing room for us. So, Dr. Singh, I've been confused by this part of it. So, if we're being told 80% or so are having mild or no symptoms, and most of them haven't even been tested yet, and then you've got 20% who have seem to have symptoms, and then a certain percentage of them suddenly get in this extremely perilous position with their lungs, not working, and their hearts being damaged, and their kidneys being damaged. It seems like this disease is incredibly selective.
Again, it isn't selective. It's actually it's based on our immune systems. We've had previous shows and we're talking about boosting our immune system, and we know that the elderly, it's affecting the elderly population, remember, because their immune systems, as you get older, age, and they're not as effective as when they were younger. And so what we're seeing is, and of course there's comorbidities, the body's healing. When you have a disease state like diabetes or heart disease or lung disease, your body's fighting that. Even smoking, your body's cleaning its system. It's spending a lot of its energy cleansing itself, fixing itself. And so it has less time to devote energy to the immune system. So this is why it's always purifying the kidneys, the lungs, the liver. It's always working. It's when you're sleeping, when you're not doing anything, it's working. And so what you have is the population in general that are young and robust and actually good immune systems. But remember, this thing is affecting young kids. It's going through a wide spectrum. But the general rule is if from 60 to 60, 70, you start seeing morbidity rates increase. And that is because of one, the decrease in the immune system, And the comorbidities, when we say comorbidities, what does that mean? It means those disease states. And so it's affecting, so the body's trying to keep up, and it's fighting, here's the disease, and the body's trying to fight it. And so it's not able to overcome it. And so it's overwhelmed. Like, for example, we know that it attacks the lungs and the angiotensin and enzymes system. So that's what gives the lungs, as Frank will tell you, compliance. It's what when you take a deep breath, your lungs can breathe. And then, of course, those enzymes do a multiple of things. You can Google it and find out. But at the end, it's attacking certain receptors that prevent you from actually, when you take a deep breath, you're bringing fresh oxygen in, and you're getting rid of the CO2, which is your toxic stuff. But with that oxygen molecule, you're able to create things like, hydrogen peroxide and lysosomes that go active. So and of course the Krebs cycles, that the life cycles of the cell. So oxygen is a key component. So you knock out the key components of the body. What you're now having is this is basic science, is that you're losing the main ingredient, the main feed that's coming in to give the body what it needs. Other than nutrition, it needs oxygen. Your body will die in 4 minutes without oxygen. It can live, roughly weeks without food and days without water. But you knock that oxygen off, you're dead. And so at the end of the game, oxygen is a component that's very important. So if anything that affects that decreases the survivability of this disease.
So with 91%,
Frank, you want to add
go
anything
ahead.
to that?
I was going to ask Dr. Baciewicz, the stats in Michigan, at least a day or two ago, the stats in Michigan were that 91% of all of the fatalities were of people 55 and over. I don't know if that's current today, but that's been pretty consistent over the last 2 months or so. And if that's the case, is that what you're seeing? One, is that what you're seeing there, that it seems like the majority of the fatalities are over 55? And then if that's the case, then can you guys foresee a gradual opening of everyday life in other areas with more of a stronger isolation for the people that are in the most danger?
Well, let me just comment on something that Dr. Singh brought up. Now, I certainly agree with you that older patients are the ones who are succumbing to the disease, but just to give you my own personal experience, we have patients who are 38 and 44 who have been ventilated and been very sick, and some of them have been pretty healthy people. Now, one of the patients that just was talking about happened to be a nurse, so maybe she got exposed with a high virulent load, and so that may be a bit of an anomaly. But we have seen healthy 38-year-old patients. Now, some of these younger patients that we've seen have been overweight and been a little bit on the obese side, which is one thing we've also seen. Heavier patients seem to be more susceptible to the disease. The other cohort of patients that we've seen have been nursing home patients, no matter what age they are. Seeing to be in a nursing home is not a good prognostic issue when you come to the hospital. We have a lot of patients from nursing facilities who have come to the hospital. Some have recovered. And just again, to give you my own personal story, I had an 82-year-old patient that needed urgent cardiac surgery. He's 82, so his risks are higher than normal, and he needed valve surgery and coronary surgery. So normally we would try to have postponed this, like I mentioned, to save equipment and not to use the operators, but his symptoms were such that he had to be operated. He's done very well. In fact, he's going to hopefully be going home later today, but he did very well. He's 82. He was in a hospital with all these other patients with COVID. He didn't, so far at least, contract the problem. So there may be something else here that we're going to figure out.
Absolutely.
Because he's an 82-year-old patient that had heart surgery, tremendous immunocompromised when you have that type of situation, and he's done fine. You've got 38-year-old and 44-year-old patients that are on ventilators. One of them is on an ECMO machine right now. So it doesn't add up. And
I totally agree with you. And
one
some of those
thing
are,
I'm gonna say, maybe there's something about
yeah, I agree with you.
here or something. I don't know. There may be some other factor we haven't put into it. But yes, the older patients, to give you a long answer to your question,
Yeah.
the older patients are more susceptible, but certainly there are exceptions. And we've seen older patients that, I'm just giving you one example of a patient that I did not want to operate on, but had to, who have done well. So, it isn't, nothing's 100% is my answer.
Right.
And Frank, I totally agree with that. And in fact, we've seen even younger patients than that been affected and recover or tried. I think it's the recover rate that we're also looking at this. No one's, I've seen this disease affect a wide spectrum of populations from young, from infant to the elderly. And so we're seeing it affect animals. So this brings an interesting, whole different perspective on this. I've never seen something like this in my lifetime. But at the same point, like I said, the more I've seen very healthy, very healthy young people get this disease, and so it is nothing that we should take lightly and say, okay, well, I'm young and I'm immune to it. No, you're not.
Well,
The isolation.
Let's kind of finish up with that statement, because I think that where we're at right now is, you look at the statistics, and at a point, decisions are going to have to be made statistically, and we're going to have to figure out how to protect the most vulnerable while we also, continue living. And those two things, if this is our new reality, COVID-19 exists in the world today, so we're going to have to figure out ways to navigate through this process to protect our vulnerable populations and release the others that perhaps have already gone through it, or that are probably going to be pretty stable. It's going to be math, right? And so testing is going to be incredibly important. If we can get a good antibody test, that'll be important. And then time, right? It's just going to be about time. So I want to thank you guys for joining us today, and I'm really grateful that you took the time, Dr. Baciewicz. I know you're an incredibly busy person, and thank you for serving on the front lines. And you're laying it on the line every day, and we're grateful for you and for your team and all the people down there at the Detroit Medical Center and the rest of the hospitals.
Well, thank you for having me, and I'm happy to give you a follow up in the future if you would like that. So
that'd be great.
Thanks, guys.
Well, we just to remind you, Dr. Singh, his website is drbishamsingh.com, and you can get information about his campaign. You can also get a lot of the information that he's getting from Washington, D.C. and from the White House with regard to current information on that research. And then if you need help, if you want to get help, go to heritagechurch.com. There's a button that you can say get help, and especially with regard to food, we've been feeding hundreds and hundreds of people as people have been losing their jobs and things. If you'd like to give help, there's also a button on the heritagechurch.com website to give help. You can donate food that's non-perishable. You can donate money, particularly to help support the initiatives that Dr. Singh is leading with regard to N95 masks for our frontline workers and those that are serving in the hospitals, and then also for food for the hospital workers, the doctors, the nurses, the janitors, the security guards, and all the other people, so that when they're done with a long shift, they don't have to go to Kroger and spend another hour finding food. They can get that there. So both things you can donate at heritagechurch.com as well. So if you get help and give help, heritagechurch.com, drbishamsingh.com, you get more information as well. So thank you so much for joining us, and God bless you, and we'll see you on the next episode.
Thank you.
All right. Bye-bye.
Good.